Good morning. This meeting will now come to order. Due to some traffic delays, we have a board member en route, and Secretary Johnson was just assigned a juror number and is doing her civic duty. So we will be starting as a subcommittee this morning. So we will start as a subcommittee. Please note that this meeting is being recorded, and we will start with a roll call, please.
Good morning, Dr. Sandra Hernandez. Secretary Kim Johnson. Richard Kroenig.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell. Dr. Richard Pan.
Present.
Don Moltz. We have 3 present, and we will invite members who show up a little bit later to state their names so we have roll call complete.
Thank you very much. Moving to today's agenda. So of note on today's agenda, we have 2 main informational items. One is continued discussion about data submission enforcement, and our second item is spending target enforcement specific to assessing performance. I'll remind the board and public that we will not have a board meeting in September. You get a month off, but we will see everyone back at the end of October on October 28th. So moving on to executive updates, I'm going to start with some information about the Rural Health Transformation Program. So we talked last month about some aspects of the Federal Budget Reconciliation Bill, or H.R. 1, which makes nearly $1 trillion in federal cuts to the Medicaid program, to exchanges, to food stamps and other SNAP, another important program over the next decade. H.R. 1 also includes the Rural Health Transformation Program, which provides $50 billion over 5 years to strengthen healthcare access in rural areas. So of the $50 billion, $25 billion will be distributed equally among states with an approved application. So every state that gets an approved application will get an equal share. And then the remaining half, or $25 billion, CMS has stated that the funds will be apportioned based on the scores of the state applications. The law requires CMS to consider certain factors when distributing these funds, such as a state share of population that lives in a rural part of a metropolitan area, its share of rural health facilities compared to the nation, and the situation of hospitals that serve a disproportionate number of low-income patients with special needs. Next slide, please. Each state is required to submit a detailed rural health transformation proposal to CMS, to the Centers for Medicare and Medicaid Services. We're awaiting final guidance about the official submission. The feds will be releasing a NOFO, or Notice of Federal Opportunity. They've just started to host webinars, so we're starting to get some more details from CMS, but no official guidance yet. And CMS is required under the law to approve or deny applications by the end of this year, by December 31 of 2025. To receive funding, states have to submit a rural health transformation proposal that addresses the following goals that are shown on this slide. So how we're improving access to care, improving health outcomes, promoting the use of technology, strengthening local partnerships, expanding the rural workforce, advancing innovation, supporting system sustainability, and identifying causes for rural hospital closures. So those are the required goals that are noted in H.R. 1. Next slide, please. So those goals must be supported by at least 3 of the following 10 activities shown on this slide. Promoting evidence-based interventions to improve prevention and chronic disease management, providing payments to healthcare providers, although it's noted that it can't be supplantation, promoting technology-driven solutions for prevention and management, providing training and technical assistance for developing and adopting technology-enabled solutions that improve care delivery in rural hospitals, recruiting and retaining clinical staff to rural areas. The law specifies a 5-year service obligation, which is quite long compared to the programs that the state typically has. Providing technical assistance, software, hardware for significant technology advances to improve efficiency, cybersecurity, and patient outcomes. Right-sizing healthcare delivery by identifying needed services, facilities, et cetera. Supporting access to opioid use and substance use disorder treatment. Projects that support value-based care, and additional uses designed to promote sustainable access to high-quality rural healthcare services as determined by CMS, the Centers for Medicare and Medicaid Services. Next slide, please. So stakeholder engagement is going to be quite critical. The Health and Human Services Agency has requested that HCI oversee submission of California's proposal. So HCI houses California's State Office of Rural Health, and our State Office of Rural Health is leading the proposal effort, guided by input by rural health leaders and feedback gathered through broad stakeholder engagement. So our stakeholder engagement will start with a webinar next week on September 4th, along with a survey released after the webinar that day to ensure stakeholder feedback is captured, especially from rural communities. So we will be taking in all of your input and integrating that into the priorities for California's rural health transformation proposal. We'll also offer additional webinars and listening sessions through September to review the priorities and strategy of our state's rural health transformation proposal. So we do encourage you to sign up for our rural health mailing list, which can be found in the healthcare workforce section of our website, or you can use this as a live link. So again, if you have questions, you can email those questions to our State Office of Rural Health. And we look forward to engaging with all of you to put together the strongest proposal we can for California. So we have our State Office of Rural Health expertise. They've been for decades providing support to rural healthcare providers. We have our workforce strategies and experience. We're pleased to be working with Margaretta Brandt and her folks about value-based purchasing, relying on HCI's data, and of course collaborating with sibling departments, including Department of Healthcare Services and others. So again, look forward to your engagement as we put together California's proposal. And with that, I will turn it over to Vishal Pagani. And turn over.
Thank you, Director. I'll be covering a few research articles, our quarterly work plan, some important dates on the board calendar. So starting first with a research article on the National Bureau of Economic Research working paper from Zach Cooper and colleagues. So this paper examined the effects of mergers between hospitals and physician practices on prices and quality for labor and delivery services. Using several data sources, including Medicare data on provider practice and specialty and commercial claims over a period from 2011 to 2016 for labor and delivery admissions, the authors found in the years leading up to an integration event, which is when a merger or acquisition took place, treated providers, those who eventually merged with an entity, and control providers, those who did not merge, had similar trends in average prices, but in the year of the merger between hospitals and obstetricians, both hospital and physician prices jumped sharply, and 2 years post-integration, on average, hospital prices for labor and delivery increased by 3.3%, and physician prices increased by 15.1% compared to a matched sample of non-merging control providers. Next slide. So to examine if the price increases are driven by quality improvements, the authors examine a range of quality outcomes relevant to childbirth, including C-sections, travel distance, and investments in full-time personnel, beds, and technologies. They did not find any detectable improvements in quality measures post-integration. On the contrary, there's suggestive evidence that quality declines with post-integration C-section rates, statistically significantly increasing. The authors offered an explanation for this. They suggested that the evidence for a decline in quality occurred because C-sections could be overused and a more profitable source of revenue for providers. The authors conclude by noting that taking action against many physician hospital mergers could preserve competition in healthcare markets and keep prices from rising. And then taking us to our next research article. So this is a second piece that I'm covering. It was published in Health Affairs Scholar by researchers that covered California, which is the state's ACA marketplace. In this piece, they use a combination of administrative enrollment and claims data to examine the total cost of coverage. So this is including the net of any advanced premium tax credits or subsidies, plus out-of-pocket costs for covered California households. They found the following. In 2022, households with incomes under 400% of the federal poverty level spent an average of $2,519 on coverage, while households with incomes over 400% FPL spent an average of $9,012. To understand how policy changes such as ARPA or American Rescue Plan Act enhanced subsidies improved affordability, the authors compared the total cost of coverage in 2019 and 2022. So prior to the ARPA enhanced subsidies, the average cost of coverage for households below 400% FPL was 8.6% of household income. In 2022, the average cost of coverage fell to 6.2% of household income, driven primarily by lower net of subsidy premiums. And for households with incomes above 400% FPL, the average cost of coverage fell from 11.6% in 2019 down to 8.9% in 2022. So I'll take us to our quarterly work plan and review kind of what's ahead for the rest of 2025 and outline some plans we have for 2026. So this is broken down by program area. In September, we have an advisory committee meeting where we'll discuss the timeline of changes brought on by HR 1 or federal budget reconciliation, just as we did last month with the board. Data submission enforcement will be another topic with the advisory committee, and we'll introduce spending target enforcement. We'll provide a quarterly update on cost and market impact review, the program, CMIR program. In October, we will just have a board meeting where the board will vote. This is tentatively scheduled on the scope and range of data submission penalties and discuss a few topics, which is spending target enforcement and continuing a discussion on assessing performance. We've tentatively slated an update on the Monterey Hospital Market Competition Study, and then a quarterly update on the CMIR program. In November, we'll have a board meeting, again, where we've also slotted in time for a board vote on the scope and range of data submission penalties. So this depends on whether or not we accomplish this in October. We'll also discuss a few other topics, including continuing discussion on spending target enforcement. We'll move on to technical assistance and public testimony. We'll provide an update on Data Submission Guide 3.0 regulations. And then during November, we'll also provide an update on the behavioral health spending definition and a summary of public comments we received, as well as advisory committee feedback. In December, we just have a board meeting on the calendar, and then we also have time held for a tentative vote on the data submission penalties. And then we'll also continue discussion on spending target enforcement, where we'll continue, depending on how far we get, a discussion on technical assistance and public testimony. And then we also plan to provide an update on hospital spending measurement in December as well. So I'll take us to our next slide, which is future topics beyond December 2025. So this includes data submission enforcement, which will need to be codified through regulations. We're currently planning an April effective date. Spending target enforcement, we'll continue to discuss the topics listed here. We do have an item here for follow-up on high-cost hospitals and factors considered in identification as part of our annual revisiting. And then promoting high-value system performance. We'll continue our work on, depending on how far we get on additional analyses, whether OCA is ready to recommend a behavioral health investment benchmark. And then taking us to assessing market consolidation, we'll continue to provide updates on material change notices received, any transactions receiving a waiver or warranting a CMIR, and then the amount of time it takes for us to review notices and complete CMIRs. So I'll just take us to our next slide, which is our board calendar. So we've scheduled our 2026 public meetings. They'll typically occur on a Wednesday for the board. And then the quarterly meetings for the advisory committee are also listed here. So I'll provide a few other updates that are not listed on a slide. So as a reminder for the board and the public, the comment period for OCA's proposed behavioral health spending definition and measurement methodology began on August 4th and concludes on September 3rd. The notice of publication and the definition and measurement methodology along with the associated code set can be found on the OCA website. I'd also like to give an update to the board and the public on our engagement with health plans as we approach the September 1st due date for annual THCE data collection. This year, we have conducted 5 all-plan submitter work group meetings. This past May, 51 plans registered to submit data to OCA. Since then, OCA has responded to dozens of email inquiries from 22 submitters. Throughout July and August, we conducted one-on-one technical assistance meetings with 38 plans to answer any questions they have ahead of their data submission. 21 plans have submitted test files to our THCE data portal. And so far, 6 plans have already submitted production files of 2023 to 2024 data. And then my last slide is just a reminder about our slide formatting key. Yellow indicates informational items for the board and decision items for OCA. Green indicates areas where the board has decision-making authority. And I'll turn it back over to the director to facilitate any discussion.
Any questions or comments from board members?
A question for you, Elizabeth. How much do you anticipate coming from the Rural Health Fund to California?
So again, half of the funds will be equal. So if every state were to get the same amount, we would get $1 billion over 5 years. And we just don't know what all the factors will be. CMS has just started their webinars, so I participated in one on Friday, and the team is attending several this week to get the basic information. I think we won't know until the NOFO is released and we see the specifics about how they're defining rural areas and what they're giving points to.
So not enough probably to try to move towards some kind of global budgeting approach for rural hospitals, which might facilitate access and quality improvements.
I certainly think all options are on the table, and we welcome the best thinking about this. I think it is important that this clearly cannot be just backfilling. And so I think folks are aware that the word transformation is used for a reason, and we need to do something different, including potentially looking at the way we're financing. So, but we're just in the initial stages of gathering information.
And very minor, I don't know if you're going to reuse these slides. The first slide said that there's $50 coming for the rural health fair.
We've left out the billion part. Thank you. We should add that. Thank you.
Might be helpful. Okay. And Vishal, one comment and one question. I saw on the work plan that the update on hospital spending measurement is in December. That may be the fastest that you can provide an update. I'm sure that hospitals are arguing strenuously for information as soon as they can get it, and I would support that. I mean, I think it's incumbent on us to move as quickly as we possibly can to provide clarity about how hospital spending will be measured if they're going to be held to or given that they're going to be held to a target.
Yes, we understand the urgency and we're trying to move as fast as we can.
And then one question, and this may be, I know we didn't have the work plan for next year yet. We had talked about reviewing the targets on some semi-regular basis, and I would hope that would get worked into the work plan at some point. We set these targets, the 3.5 trending down to 3, and I think when we did that, we said we would review that over time, and it would be good to have that in the work plan as well.
Yeah, we could take that back. Yeah, as far as yeah, that would fit with our board calendar, and then we're also going to have 2 years of data collection on THCE. That's at the payer level. So we're going to collect the 23 and 24 data in September. So those are pre-target year data. So the targets were not in effect. So we can't draw too many conclusions from that data, but it could be used to kind of get a lay of the land of what's happening in spending.
And there'll be substantial new information both about median income growth, household income growth, as well as health spending growth more generally, both nationwide and in California, and other information we can be looking at, I think.
Yes.
Dr. Pan, did you have?
I would just say I concur with Dr. Kroenik's comments.
Thank you. Any other comments or questions from the board on the executive updates? Okay, with that, we'll take public comment on the executive updates.
We'll now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access, we'll alternate between those in the room and those attending virtually. Those dialing in can press *5. We invite you also to provide written comment, if necessary, at the email address provided on today's agenda. Please keep your comments to 2 minutes or less so we can hear from as many folks as possible. Please note that while the board is committed to communication and transparency, board members will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that's not included on the meeting agenda today, except to place it on a future meeting agenda. Thank you. I'll now go to the podium. Press the mic to green. Yep.
Janice Rocco on behalf of the California Medical Association. In terms of the Rural Health Relief Fund, I did want to mention 2 weeks ago, CMA held our annual medical group symposium and had the acting national Medicaid director speak, and we asked her specifically about how they would make decisions there. And she did say that they were hoping for states to collect as much data as possible to have data-driven conversations, and that they certainly recognize that each state is different and should be able to design their own programs. So both of those things sounded good. Since then, we did put some together information about rural physician practices and the decline over a period of years that we gave to Cal HHS, and make sure HCI has it. But we're also putting together some additional information in that vein that we'll share. But if there's anything that you can think of we might have access to, we can try to put something together quickly given the tight timeline once the application goes forward.
Thank you.
Thank you. Looking virtually. Seeing no hands raised, back to the podium.
Thank you and good morning. I'm Victoria Valencia from the California Hospital Association. First, we appreciate you highlighting the Rural Health Transformation Program created in response to concerns over the impact on rural hospitals from the One Big Beautiful Bill Act's $1 trillion healthcare cut. Even before OBBBA, many of our rural hospitals were at serious financial risk. Madera lost its hospital, which only reopened through the incredible support of HCI under the Distressed Hospital Loan Program. Another hospital, Glenn Medical Center, recently announced plans to shut down completely due to upcoming reimbursement cuts. While the Rural Health Transformation Program will not come close to fully addressing the devastating impacts on rural patients and communities, it is a vital opportunity for our state, and we urge that it be used to sustain access to care in rural communities. We welcome HCI's leadership on this important program and ask for close engagement with rural hospitals on this work. Second, we would like to express disappointment at the continued lack in balance in what research is brought before the board. Today, OCA reviewed a study that is critical of clinical integration between hospitals and physician groups. It looks at one insurer, one service line, and does not address patient affordability, insurer profits, or broader outcomes like access and coordination. In short, it is incomplete evidence and does not represent the full story that patients care about. Last month, OCA presented research that showed higher insurer concentration can be associated with lower hospital prices, and yet OCA did not discuss whether higher insurer concentration also led to lower premiums for consumers. As summarized in our letter this month to you, the literature shows that greater market power for health insurers also increases their leverage with purchasers, raising premiums for consumers. So clearly this is not a situation OCA should encourage, and we ask OCA to provide a more balanced evidence that tells the full story. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the podium.
Beth Capel with Health Access. Like others, we're pleased to see the administration moving forward to apply for grants for the money for rural health and recognize also that it's utterly insufficient compared to the cuts. And are pleased that it's HCI handling this given your good record with distressed hospitals and recognizing what a distressed hospital is and is not. So we appreciate that. We also, like others, recognize the devastation that will be caused by HR 1 and spent some time in our correspondence discussing that as well. We would also encourage looking again at what median income has done and what healthcare costs have done. We, as a result of some of the other correspondence, looked at inflation, and really inflation's now down to 2.7%, which is below the 3.5% target. And we think if you look back over 20 years, you'll find that inflation's been relatively modest. But you chose to base the target on what consumers can afford, and that's certainly what we continue to support, and that was median income slightly adjusted. So thank you.
Thank you.
We'll go back to the podium.
Hi, Anate Miller is on behalf of the California Association of Health Plans. In terms of telling the full story, I would just like to note that health plans are continued partners here in affordability with OCA. And with strict public reporting requirements, the medical loss ratio on the federal and state level, in addition to strict rate reviews and solvency requirements, health plans already operate under some of the tightest cost control frameworks in the country. These safeguards ensure that premium dollars go back into patient care, not unchecked profits. I note that because I just want to emphasize that health plans are partners in OCA's initiatives. We are here on standby to provide information and analysis wherever necessary. So in terms of concerns, we too have concerns about the impacts of HR 1 and are prepared to assist OCA in providing information wherever needed. Thank you.
Thank you. Seeing no virtual hands raised, that concludes public comment.
Thank you. And returning to the roll, we note that Dr. Sandra Hernandez has arrived and will take over as vice chair. Thank you.
Good morning. I think we're going to move on to item 3, which is a consent item. Deputy Director Pagani, anything you want to comment on?
Yes, we just have the meeting minutes. The minutes and any written public comment we received since the last meeting have been distributed.
Thank you. Can I entertain a motion to approve the minutes?
It may be a technicality, but we should declare that we actually have established a quorum because we had not until this point.
So let's declare that we established a quorum. Thank you, Dr. Pan. Okay, no problem. Important technicality. I didn't realize I was the quorum.
I'll move.
Ian is moved. Is there a second on the minutes?
I'll second the minute.
Dr. Pan. Okay. With that, we'll take public comment, or if there's any comment from the board. If not, we'll entertain public comment.
All right, we'll now take public comment on this agenda item only. Looking virtually, seeing no hands raised and seeing no one at the podium. We'll give it a moment. That concludes public comment on this item.
Great. We're ready for a vote. Will you do roll call, please?
Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson. Richard Kronick.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell. Dr. Richard Pan.
Aye.
That's 4 ayes. The motion passes.
Great. Any other comments or discussion from the board on that item? Okay, if not, I will give it over to Vishal to take up our data submission enforcement item.
Thank you, Dr. Hernandez. For this month, we have 2 informational items, an update on data submission and enforcement, and a continuation of our spending and target enforcement discussion from last month's meeting. I'll hand it over to Assistant Deputy Director CJ Howard to cover this portion.
All right, good morning. We'll start with the update on the data submission enforcement. Go to the next slide. As a reminder, we have included on this slide the statutory requirements related to penalties. Under the top portion of the table, we see that the board approves the scope and range of data submission penalties, as well as the penalty justification factors for assessing data submission penalties. And under the bottom section of the table, we see the list of considerations under the scope and range and a list of justifications for the penalties. Next slide. In July, the board asked several questions that we wanted to follow up on. The first one was, what percentage is the proposed penalty amount of a plan's annual revenue? So this amount obviously varies by plan, ranging from 0.01% to 0.14%. On average, the $5 per member equates to approximately 0.07% of the plan's annual revenue. $5 per member also equates to about 0.06 of the 2023 commercial market per member per year spend that we reported in the baseline report. The board also asked, how does the office determine when submitted data are acceptable and complete? How would the office impose penalties when submitters are asked to correct their data? So the data submission guide defines standards for data completeness and defines data as acceptable when it has passed automated and manual data validation checks to ensure that the data are in a valid file format and layout, free of illogical or missing and incomplete data values, and free of other technical deficiencies related to file submission, storage, or processing. The data submission guide provides a 5-day period for entities to correct any issues identified by the office after they are noticed. During this period, the office could delay assessment of a penalty while an entity works to correct any deficiencies that were identified. Next slide. In addition to financial penalties, what other actions can OCA take if the entity fails to submit data? The office could take administrative action and request an administrative law judge to compel entities to comply with data submission requirements. It could also notify licensing agencies of the entity's failure to comply with California law. What will happen if an entity fails to submit data year over year? The office proposes that the failure to submit data penalty would double each year for repeated non-compliance. So we proposed in the first last month that it would start at $5 per member. So in the first year it would be $5, 10, 20, 40, and so forth. Another question was, what other penalty structures would promote timely data submission? So the office proposes that a second flat untimely data submission penalty that the office would assess if data are not submitted by November 1st. So we'll kind of go through the same process that we outlined last month with some of these updates incorporated. So there were not any significant changes to these steps in the process, but as a reminder, the data submission due date is September 1, and submitters have 2 optional extensions that they could request. Each is 15 days, meaning that submitters could request all of September as extra time to submit if they needed to, and the granting of the second extension would be predicated upon compliance with the requirements of the first, which is that there are timely and routine updates provided to the office so that we're assisting submitters to come into compliance and submit the data as timely as possible. Next slide. So next we have the first tier of data submission penalties, the untimely data submission penalty, and this is where we have made an update in response to board input. If data has not been submitted by the submission deadline or end of one or both extension periods, submitters would be subject to an initial flat untimely data submission penalty of $10,000. Then, and this is part of the update, if the data are not submitted by November 1st, the submitter would be subject to an additional flat untimely data submission penalty of $10,000 and the progressive enforcement process, which may result in the failure to submit data penalty. So the change here is an additional flat untimely data submission penalty, which would increase the submitter's total penalty at this stage from $10,000 to $20,000. Along with this additional penalty, November 1 also sees the beginning of the progressive enforcement process, which would include technical assistance and the optional step of public testimony. If data is still not submitted within 30 days of November 1, the submitter would be required to submit a data submission plan to submit their data no later than December 31st or a date agreed upon by the office. Go to the next slide. If data has not been submitted by December 31st or the agreed upon date, we get into the second tier of data submission penalties, the failure to submit data penalty. For data submitters that repeatedly fail to submit data, each year the failure to submit data penalty amount would double. The increasing amounts are part of the updates based on input from last month's meeting. OCA would make all penalties public once formally assessed. OCA also proposes that it could adjust the penalty amounts based on changes to an economic indicator, such as the California Consumer Price Index. We could have further discussion on that. And last, OCA could continue to pursue other legal remedies in addition to the penalties to acquire the submitter's data. The office could take administrative action and could notify the licensing or regulatory agency of the entity's failure to comply with law. This slide is the visual representation of that process for a submitter who requested both extensions. We updated this visual to include what are now 2 potential untimely data submission penalties. So if data are not submitted by October 1, after there are 2 extensions, they face the one $10,000 penalty. If data is not submitted by November 1, they face an additional $10,000 penalty for the total of $20,000. This is also where progressive enforcement begins, which includes technical assistance and optional public testimony. If data is not submitted by December 1, submitters would have to submit a plan to submit data by December 31st or mutually agreed upon date. If data is not submitted by December 31st or the agreed upon date, submitters face a failure to submit data penalty and both the untimely data submission penalties. This next slide, we see the same process, but for a submitter who did not request the 2 optional extensions. That just moves up their first untimely data submission penalty to September 1. The other steps in the enforcement process would remain the same. Next slide. We saw this slide last month, but we did update the table to include the addition of the second untimely data submission penalty. This is just an illustrative and example of what penalties could amount to. And now we're hoping to get some feedback on the office's current proposal to establish the 2 flat untimely data submission penalties, establish a $5 per member penalty for failure to submit data, double the per member penalty, failure to submit data penalty in each subsequent non-compliant year, and adjust penalty amounts based on changes to an economic indicator, such as the California Consumer Price Index. Hand it over to the chair to facilitate discussion.
Thank you, CJ. Questions, comments, on the board? Dr. Pan?
Thank you for the presentation. So when you, in terms of the CPI, you would then do the amount, well, I guess now that you're doubling, then you do a CPI adjustment on top of that. I'm just trying to understand when you said you're also going to do a CPI adjustment, how that formula is going to be, how the penalty is calculated.
Yeah, so the purpose of that is giving discretion to increase the amount based off of the CPI so that the penalties years from now could still be relevant without needing to update the penalty amounts in regulation.
I guess I'm asking more about the mechanics. And the mechanics would be there's a base penalty, right? We double it because now it's 2 years or 4 years or whatever. And then you do a CPI adjustment from that base year to that point in time. Is that how you imagine?
Yes.
Be implemented? Okay. All right. And then I guess the other, I don't know if it's a question or comment, but I appreciate you did the calculation, sort of the percentage of revenue. It almost seems like it's a rounding figure. So, because it's, I mean, we're talking like 0.06%. Did I hear that correctly? So, I guess to me, that doesn't sound like much of a penalty if someone's going to be that egregious. I mean, clearly, this is a situation we're talking about where someone, it seems like they're very intentionally not doing this. I mean, we're giving people lots of opportunities to show that we're acting in good faith, and maybe they couldn't pull it off, and we're going to help them and so forth. But versus like, I'm just not really going to cooperate, right, and not do it. So that's one question. But I guess also related to that, you said, you know, we could go to an administrative law judge. And since we already have this penalty, what kind of penalties do you imagine an administrative law judge would be able to impose beyond what we're already imposing on the entity to get them to comply with the law?
So it's not so much the penalty that the administrative law judge would impose, but it would actually be an order compelling the entity to submit the documentation. And we could pursue penalties, but because the penalty that we've outlined or proposed in this structure, it would be an imposition of that penalty and in the event that they have not paid, and an order compelling them to produce the information.
And I hate to ask this, but, you know, in this environment, we've seen plenty of people ignore judges. So what power does the judge have to actually get that organization to comply? So they issue an order, then what?
What's the enforcement capability?
Yeah, what's the enforcement capability of that order?
So it's an administrative law judge order. If they don't comply, then the next step would take it to Superior Court and initiating a writ in Superior Court to mandate compliance with the administrative law judge's order.
Ian, please.
Yeah, in a similar vein, I mean, I'm glad that procedure is there, but it sounds onerous, expensive to the office, and to take a very long time with uncertain outcome. And, you know, I really hope this is an academic worry, but we have seen elsewhere under regulatory penalties, plans, and others absorb these simply as a cost of doing business. And at 0.06, I could certainly imagine that if a plan or any provider is anticipating that they're going to go well over the target, that might be a good exchange or risk to take, depending on what we decide on other penalty proceedings. So, I mean, two ways that I see to cut it, maybe there are more, is to increase that $5 substantially, or maybe it's $5, you know, on January 1 and another $5 on February 1, or you know, create something more than an annual assessment of the penalty.
Yeah, I was going to go in the same direction as Ian. I guess the question for the office is, does the information continue to be useful if it's submitted after the $5 date? And I would think the answer is yes. I mean, it might not get into the first annual report or the first report on that year, but the report can be updated. And assuming that it does continue to be useful, then some progressive penalty that every month that you don't submit, the penalty gets bigger, would I think be useful if you're inside an organization and you're talking with your bosses about what resources are needed to make this happen, and the boss says, well, penalty is the same regardless of whether we missed the date, and so it doesn't matter anymore, that it would be better to be able to say, no, actually it continues to matter, and we ought to try to get this done.
Yeah, the data would be important, not just for the payer's performance, but also the physician organizations that they attribute spending to.
Yeah, and so every month that the data is not submitted, the penalty goes up, would make sense to me, as Ian was suggesting. And then very minor to your question about CPI, I don't have strong feelings about this one way or another. If in 5 years it means a 10 to 15% increase, if we do get inflation between 2 and 3%, presumably in 5 years the board will be reassessing the penalty structure anyway, and I'd probably let it go, but don't feel strongly about it.
So we appreciate the board's feedback that you think these numbers are potentially too low. If we could go back to slide 29, I guess it would be helpful to hear from the board what you think would be. So I hear both, maybe these are too low, that you're concerned about it being a cost of doing business, and also potentially that you're looking for a structure that increases to incentivize submission.
Dr. Pan.
Yeah, I mean, I think, well, first of all, of course, we want to let people who are acting in good faith to act in good faith, and people who aren't, that there needs to be consequence. For that, I think one of the things that's going to be helpful is trying to understand some of the timing of the data in relation to how we could use it and how important it is, because obviously when someone's not submitting data, that becomes a whole, depending on how big the organization is and our own ability to look at what's going on, right? So it's not just that they didn't turn in the data, it's that they're actually blocking our ability to do what we've been tasked with by the law, by the legislature and the governor and so forth. And so that's a serious consequence to us too when they don't turn it in. And I think that there needs to be a recognition of that. It's not just that, oh, well, we're not just penalizing people for, I'm not saying for the fun of it, it's not the right phrase, but just because we just want to make people do stuff, is that data is critical for us to be able to analyze what's going on. So when someone doesn't do it, that becomes a big problem for us. So, and also that they turn it in a timely manner. So I do agree with this idea of, over time, but at the same time, there's certain critical points of time where the data is particularly important for us to be able to do our job. And if it's past that time, probably less useful. I'm not saying not useful at all, but less useful for us, because basically we can't hold everything up so that it wouldn't incorporate. So I don't know whether that should be incorporated into the way we structure a penalty process or not, but we need to acknowledge the fact that at a certain point in time, we can't hold up everything because we're still waiting for this one piece. We have to move forward, but then that's going to be missing, and then we have to figure out what to do with that missing information.
So let me agree with our colleagues on the theme here, which is obviously we are going to provide, extensions as necessary. I sort of think after December, really at that point, you should accelerate the penalties on a monthly basis so that there really is an accountability for the lack of timeliness of submission of that data. And I would look at the December cutoff as the point in time in which you'd start to accelerate it much more dramatically than what you've currently proposed.
And I think that is what the team has put together when the time frame is. We really need the data in the fall to be able, and if CJ or Vishal wants to comment more, but we really do need the data in the fall to include it in our THCE data, and so that's why we have these penalties starting January 1st.
Any other comments from the board? Rick?
Just in response to Elizabeth's question about, what numbers might make sense. I mean, maybe, the December penalty, I'm looking at the $10 a month, which would then be, a hundredth or a little more than 1/100%. And then maybe $5 a month for every month after that is not submitted, or something like that. I'd be interested in comments from the public on that, but.
Dr. Pan?
So from what I'm hearing from the staff, though, is that you need this data, by end of December at the latest, right? Otherwise, you need it in the fall. And so while I don't disagree with having accelerating things after, I'm also worried about, at that point, if they turn it in April, I guess it's better than nothing. But at that point, it's a little late for the staff to be able to use that data to help us make whatever decisions we need to make. So I do wonder whether, I definitely want to give the opportunity and flexibility earlier on, that we really do need the data by the end of the year, and whether there's something to more leverage to get someone to get going before the end of the year so that we get the data, especially if they're not being particularly cooperative. This is the place where I want to give a little latitude to say, okay, look, they really are trying, but it's not that we asked them in the fall, can you please provide the data in the fall? We've asked them for a while, right? If I got it correctly. The requests and the standards are there. This is not a situation where, oh, by the way, we're asking you, can you please turn it in? We gave you a very short timeline. You've known for a long time. So if you can't get it in the fall, something's going on. You should be asking for technical assistance before then if you're having trouble hitting that deadline, right? And some of that may also have to do with, and again, appreciate clarity from the staff, at what point do we expect the plan would have the kind of the data that we're asking for? When do we expect the plan would actually have, reasonably would have that data available to start turning over to us, right? Now, how much lead time do they have to really do the submission, to do whatever thing they need to do? What point, it's like we want data up to what point in the calendar, right, before that to submit to us, and how much of a gap is that between that and the actual submission date may be important to know as well. So, or at least to understand. So, I want to be reasonable to the plans. I want to, and because ultimately, actually, I don't want the penalty. I want the data. But what can we do to try to provide the kind of, incentives and, sticks so that the data will show up? And I guess that's the question I'm asking in terms of, especially when we're thinking about timeline, right? When would a plan would expect would have the data, at least and then submission to the time when we absolutely need it, and then what kind of things do we do in between to make that happen? I'm sure you've thought, you do have different stages, so I appreciate that. But I'm just trying to have a better understanding of that in terms of trying to figure out our incentive penalty structure.
CJ or Vishal, anything you want to comment on? Helpful feedback from the board, anything else?
We could take this in. I do want to say that, we'll kind of think about kind of some more progressivity in terms of the penalties, but also just a reminder that this could be a first year approach, and it could be updated second year depending on the experience, but do kind of understand that we do need the data, and kind of how do we balance kind of the size of the penalties. So we'll take that into consideration.
Okay, anything else from the board? Thoughts, feedback? Sure, Dr. Pan.
I do want to acknowledge, at least in my prior discussions with the staff, that so far, from my understanding, is that the payer community has generally been cooperative. I mean, this is not because there's someone out there we're worried about at the moment. But of course, I think it's important we set the rules ahead of time so it doesn't look like we're tailoring it against any particular entity, but that, look, we just created the rules. This is what they are. And so we don't have to go back and, I mean, not that we can't make revisions, but that we are pursuing a fair and justifiable process.
And I think we've heard from public comment that it is the intent of plans to be supportive of the work of OCA, and so their cooperation, I'm sure, will make these penalties irrelevant, hopefully. Okay, I'll open it up for public comment.
We'll now take public comment on this agenda item. Looking virtually. Seeing no hands raised, we'll go to the podium.
Beth Capel with Health Access. We want to thank the board for the discussion. We want to add a few things to it. I want to remind the board that what the law speaks to is knowingly failing to provide the information. That's a legal standard. It's not you can just hand out penalties like pizza coupons. It's literally a legal standard. There's an even higher standard for failing to report complete and accurate data, which is willfully, which is a very high standard and one that's not easy to prove. With respect to what's proposed, we're sorry to say we don't find it sufficient in any respect. We don't find the penalty amount and range sufficient. I looked yesterday at the filings for next year for rate review. We're talking literally billions of dollars in premiums. One carrier that I looked at is charging $700 to $800 per member per month. In that context, $5 is nothing. We did for you in our letter the arithmetic. If you take a small insurer that comes in at 4.5% instead of 3.5%, that's $15 million. Their incentive to avoid reporting at that point is considerable, and I think the board in its discussion has already acknowledged that. Second, we don't think the degree of public transparency is sufficient that has been proposed. What's been proposed is that there would, once a penalty is levied, that would be public. We think at every step along the way, the board and the public should be informed about whether we're in the happy place we are now, where most payers complied and almost all of them promptly, or whether we are in an unhappier place because the incentives have shifted. And I think we need to know that and not to have, I was surprised to discover that there was a non-compliant payer, and that shouldn't have been. Not just that I was, but that the board and the public and policymakers more generally should know. It will also help to build the case that the payer has knowingly failed to provide the information. The third point we'd like to raise is there's a standard that's used at DHCS called CART, Complete, Accurate, Reasonable, and Timely Data. This data is complete in a technical sense. You've just had a discussion about timeliness. We worry about reasonableness. We worry about another circumstance like we ran into with North Bay, where they've been reporting Medicare Advantage as commercial, and anybody who understood markets and looked at it would have caught that.
3 minutes.
We're worried that, yes, ma'am. We're worried that this data, we will also have data in this circumstance that doesn't meet the reasonableness test once your staff gets in and starts working with it. So we think all those standards matter, and we would encourage that there be measures on each of them for the staff to use. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Good morning, everyone. Katie Bassler from Salinas Valley Federation of Teachers and California Federation of Teachers. Thank you for the conversation and the discussion regarding the penalties. We also feel that they're going to be insignificant. What we are looking at in Monterey County, I'm sure you're seeing statewide, but we just have that special little Monterey County increase, Our most restrictive plan for family is going up approximately $600 a month. These are educators that are starting between $60,000 and $70,000 a year. Our plan is we meet on Wednesday, and we are looking at conservatively 15%, but probably upwards to 17% increase across all plans. Our labor sisters and brothers in our area are in different networks are looking at between 20 and 25% increases. The profit that these plans and hospitals are experiencing are significant. I don't know what that amount is going to be in order to incentivize that they submit their data, but those that they are charged to serve are really going to be hurting in 2026. We'll continue visiting and advocating for something that makes sense and makes it right for people to have access to affordable health care. And again, we always thank staff and the board for their help.
Thank you. Looking back virtually, no hands raised. Back to the podium.
Janice Rocco with CMA. And since this is a time for comment, not questions, I'll raise this as a suggestion, even though it's something that OCA might already have in their work plan. In terms of the data submission, I know with the health payments database, the HPD, that there was a test phase for the plans so that they would sort of know how to get it right and have a little bit of time before the deadline ever started in terms of making sure the data submission works smoothly. So I would think that would be good here. That said, I don't know what the difference is between the data that the plans already submit to the HPD, the claims data that comes in that situation versus the data that would be coming in here. Maybe it's incredibly similar and almost the same, but in any case, thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment.
Thank you. Let's move on to item 4B, discussion of the spending target enforcement. Ms. Shaw, hand it over to you.
Thank you, Vice Chair. We're going to continue our discussion from last month's board meeting. CJ and I will be kind of tag teaming this portion of the agenda. So we're going to focus on enforcement considerations for the next several slides. As a reminder, we'll discuss other parts of spending target enforcement, such as technical assistance, performance improvement plans, penalties, and more in future meetings. So this slide cites to our statute. Enforcement considerations are under the office's authority, and today we're asking for feedback from the board and the public on what factors should be considered when contextualizing spending and determining which entities receive enforcement steps. Next slide. So we showed this enforcement process flow last month. For the purpose of today's conversation, we're focused on the 3 steps within the yellow box that's highlighted. So the second step shown here is, was the target met? And then if it's no, it proceeds to the next blue box, which is OCA sends entities that missed the target a letter. And entities have 45 days to respond, and they have the option to provide more information. Under step 4, OCA would then assess performance via a set of established enforcement considerations. As I said on the previous slide, the 4th step, this 4th step helps OCA contextualize entities' spending and determine which entities receive which enforcement steps. Next slide. So I want to give an overview of how enforcement considerations could work. OCA will report entity-level spending growth to determine which entities exceeded the spending target. Per statute, if an entity exceeds a spending target, the office will provide technical assistance to the entity. Enforcement considerations are factors, characteristics, spending attributes, or other circumstances that OCA could consider when determining which entities proceed along the progressive enforcement approach, which includes technical assistance, public testimony, performance improvement plans, or financial penalties for a given year. These considerations will not change or modify an entity's reported performance or directly exempt or waive an entity from enforcement each year. These considerations will be explored for their validity with in-depth conversations with entities and supporting evidence provided by entities and evaluated by the office. Another note that we have here is that these considerations will may not impact all entities uniformly, and in many cases cannot be forecasted and incorporated into the process and methodology to set spending targets. If the office notices consistent effects across entities, we can present to the board these observations so that it can inform future prospective adjustments to the spending target. Next slide. So this slide shows a list of potential enforcement considerations. On the following slides, we'll discuss how each could be used as an enforcement considerations. We'll pause on each one to allow for discussion by the board before moving on to the next enforcement consideration. We're seeking input from the board as well as members of the public on what we should consider in the enforcement process. So I'll hand it over to CJ to cover.
Sorry, quick technical question. So in the slide you said under enforcement considerations, I guess two slides ago or one, it said determining which entities would proceed beyond technical assistance. So I'm just trying to clarify because in the chart box, it's before we get to the provide technical assistance. So I'm just trying to figure out the timing because the process flow. The slide says beyond technical assistance, whereas the yellow box was before technical assistance. So I just want to clarify what we're talking about. So if you go to slide number 38.
Right, there's been an issue. The issue here is that by statute, we have to, for everybody that exceeds the spending target, we do have to provide TA.
Right.
But I think there's also per statute before the technical assistance, there's the opportunity for entities to provide additional information. And so that's.
So this is about the provide information prior to technical assistance.
Right. So we would do this evaluation prior to providing technical assistance. Everybody, though, that does exceed the spending target does receive technical assistance.
Okay.
By
statute. I want to clarify because there seems to be a conflict between those two slides. Thank you.
Go ahead.
CJ,
All right. So first we'll discuss population characteristics. Hopefully, as you all well know, OCA collects age and sex demographic data that allow it to factor the degree to which changes in spending may be driven by underlying changes in the age-sex composition of an entity's population. OCA could consider the extent to which an entity's population age-sex distribution has changed year to year and contributed to changes in spending. Adjusting for changes in age-sex composition may not always show a lower percentage change in an entity's spending growth. OCA would still determine if an entity met the spending target using unadjusted data, but could use age-sex adjusted spending change to determine to what degree spending growth is the result of age and sex demographic changes. On the slide, we see a chart with both the unadjusted and age-sex adjusted growth rates for submitters in the commercial market for spending from 2022 to 2023. The age-sex adjustment did change the rate of growth for 10 of the 13 shown, though not always yielding a lower value. So I think we wanted to stop and kind of solicit feedback on each of these as we go through the list, because I think we've got lots of time here today.
Dr. Patrick, something you want to say?
I mean, I think it's good for us to know if the adjustment. Actually, when we set the cost targets, I think there was even some discussion that the cost target itself should have been adjusted so that we would take, because you're right, it doesn't, the direction isn't always for like more spending, it could go the other way. But I do think it's good for us to at least know what the risk, if there was a change in the population, how much that would have changed it up and down. Admittedly, since we didn't adjust the actual cost target for that, only one direction would potentially, but it's actually good to know that, hey, by the way, actually, even though they made the cost target, we wouldn't, there's nothing else for us to do, but it was because their age, sex, their population changed in a way that actually ran in their favor, right? So I think to me, it's useful to know this, if it's available, in any regards, to know, did the demographics of the entity, change in some way that would either advantage or disadvantage them in relation to the cost target.
Rick?
Thank you. I think if we're, looking within sector, that is within commercial, within Medicare, within Medi-Cal, it is hard to imagine that the age, gender adjustment is going to matter materially. If we're looking combined, across sectors, then as Dr. Pan alludes to, we did have a sort of painful discussion early on that
Thorough discussion.
A thorough and painful for some of us.
Okay.
Discussion early on that the California population is aging, and that will cause spending to go up. I would think at the entity level, the question would be whether the population is aging differently than the statewide average, and only if it were changing much differently than the statewide average, should this be considered. And again, I think it's probably unlikely, although maybe if there are, some big change in service area or some place closes and then all the old people, go to a hospital, to a system that wasn't previously serving so many of us old people, might that happen? So, potentially to look at, but this is going to be pretty minor, and it would certainly be important to compare to statewide average change, since statewide average change in theory is built into our consideration of the targets.
Yeah, I agree with that, Rick. Thank you for that. Ian?
Yeah, Dr. Koenig, that was very helpful to me. When I saw this table, I was reassured. It resonated with my suspicion about how little that adjustment might make. And your point, I think, is key. As long as we're looking at a by market segment basis, which we are, that should stay pretty consistent. And our overall approach with the statewide target, and my bias is to follow the same approach here, is keep the adjustments simple and address, acts of God, on a one-off basis through board discussion and public input. If there were a sudden change in, say, the demographics of the commercial market, presumably that would be precipitated by something big that would end up in front of this body for discussion pretty early on.
Dr. Pan?
I agree that probably most circumstances the change would be negligible, and I think the data that's been shared with us today would indicate that there's not a huge substantive change. But one of the things I don't want to see happen is that if there is let's say a shift in a market, right, and so it's not going to be the whole state, I don't want to create a disincentive for a plan or some other entity to take on patients who they would have taken on because they're like, hey, by the way, we don't get an adjustment for this, so let's not try to find someone else to take them. We don't want to take them. I don't want to create those kind of incentives. Admittedly, again, I think it's going to be minor, but sometimes, just by the way we do things, we send certain signals to people about how they should behave, and I don't want to create a kind of behavior that if there is, let's say, an entity closes and then they happen to have a older population, other people are like, well, I don't really want to take those people on because because later on I have to go to this board and they're not gonna take that in consideration. So potentially, right? Because they don't know until we act. So that's my one caution. It's really more about what signals we send to people about what kind of behavior we want them to engage in.
I'll just point out, we do see, some of these this is a pre-spending target arrow in these data, but we do see that there are cases where it could be the difference. If somebody grew at 3.8, it could bring them down to 3.5, or, we're going to be collecting this data each year, so I'm sure this is our one glimpse of this for us in California, so this could change. But we may see that, on an entity-specific basis, to your point, perhaps it's like, well, wait, this actually could be used as a means of showing, like, this justifies why I grew at 3.8 instead of 3.5, and perhaps further, given that the office, especially as we're starting, will have so many resources, maybe that's a reason to say we're going to pursue other, a performance improvement plan with other entities so that we can manage that.
Rick?
Thank you. One last comment, which isn't on the population adjustment that we're considering here, but is a broader overall question. And it wasn't in statute, so I don't know whether this is a potential enforcement consideration. But for me, the kind of top of the list of potential enforcement considerations would be how far above target the entity is. I do imagine that we may see many entities above the target in 2025 or in 2026, and we probably don't have either the resources or the desire, well, at least the resources, to go through potential enforcement actions on every entity above the target, but the entities that are far above the target would, I think, be the first ones to be looking at. And is that a potential enforcement consideration? I know it's not on the list here, but.
Yeah, we could discuss it when we get to impact on consumer access and affordability, because it also depends on their kind of position in the market. If it's a statewide plan that's large and dominant, or it could be a plan that's dominant in the regional market. So, you could have one plan that's growing really high, but they have less people, and then another plan that's larger and still grew, but not as much. So there's kind of, who do you prioritize for enforcement?
And just to make sure I understand the context and what we're discussing, this example is about plans, and you just mentioned, Vishal, plans. I had been assuming, but maybe I'm incorrect, that this discussion covers potentially enforcement around physician groups and hospitals and other healthcare providers as well.
Yes.
Yes, thank you.
Okay, CJ, you want to keep going? High cost patient outliers? Or I don't know.
I do.
Yeah, Don. You're speaking to the mic, Don.
On Rick's comment. So the other consideration I would think is just the size of the entity. So, we have, this applies to a whole range of folks. Some are very important, some are less important for the, just for overall costs in the state. And I would think that would be an important consideration. I would hate to have us going after a lot of little fish as a first order of business. Not to say that, that enforcing this is not important, but just like that's another priority.
Yeah, I hear your point, Don, and Vishal's point, I think, was, and depending on the market, if that little fish is the only player in the market, then that might be important to consumers, right? So there's a variability there in terms of those considerations. Okay, CJ?
Yeah, so next we'll discuss high-cost patient outliers. So I think we had some initial discussion about high-cost patient outliers a couple years ago now. How time flies. The emergence of high-cost outliers has the potential to drive fluctuations in an entity's spending growth, especially as we think about potentially smaller entities. After determining that an entity exceeded the spending target, OCA could work with the entity to determine the extent to which the emergence of high-cost outliers caused the entity to exceed the spending target. In some cases, the emergence of high-cost outliers may be outside the entity's control. Including this as a factor would enable OCA to consider random or unexpected events that drove volatility in the entity's spending in a particular year.
Ian, do you have some, please?
Yeah, you may be shocked to hear my opinion on this. No, I mean, we had that discussion previously, and I learned a lot during the discussions around the hospital sector analysis and Monterey too. So much of our spending is in what plans or consider high cost claims, and those are actually the places where they have the most control sometimes. You know, we heard some eye-popping numbers about the prices being charged purchasers for and payers for certain, you know, generic cancer treatment drugs, for instance. Like this is one of the core purposes of, and why we entrust providers with the care of patients, is to make these hard judgment calls. I would resist cutting off outliers. Now, if there is a particular entity that is so small that those outliers make absolute outsized impact, I think that would be something to bring to the discussion, but it was off the bat justification for excusing from compliance. So just that.
Dr. Pan?
Well, I don't think we're talking about saying that therefore we just write off all the compliance. I think, I mean, these are a little tricky, but frankly, you know, when we think about where healthcare spending is, right? The healthiest 50% only spend about 3 to 3.5%. The sickest 10%, right, is 2/3. 5 is half, right? So, I mean, you and depending on how big your base is, you could have someone or a handful of people cause some fluctuation if you're not, you know, depending on basically how big your risk pool is, right, and how much you can dilute it out over that. However, I do also think that we should be paying enough attention to the overall healthcare market to at least be able to identify, like, okay, who would reasonably expect to be. And it's not just high costs because, you know, someone spent a lot of money on them. Is that, no, we would expect these types of patients, and frankly, I'm a pediatrician, and you know, there are certain kids who get really expensive, right? They need really highly specialized care, and there are not a lot of kids. So what happens is that a couple of kids who have in that category, if you happen to pick up 2 of them, you know, you could suddenly your pediatric spend jumps quite a bit. So, so I think that, you know, there are probably identifiable circumstances where you would say, if you had a disproportionate number of people came up with this diagnosis or something, that we would look at it and see if that might have actually, you know, and you have to justify, like, why did it suddenly tip you over, right? Like, how much these couple of patients did, and it's not because they overcharged on generic chemotherapy, right? It's like maybe there was a new, like, well, let's say sickle cell, right? A new genetic therapy or something like that, right? If something tips it over, that could be. I think there are circumstances where we should incorporate that, because what we don't want to do, again, send an incentive that, by the way, because people are afraid of OCA, we're not going to make certain types of care available, right? Particularly to people with very, high cost, who require high cost treatments that probably are going to be fairly novel as well. So how we incorporate it. Now, I don't know what we do about, like, something like Ozempic or something, you know, that's a whole other story. But I think that there are circumstances in which we should look at that if they can justifiably explain and say, look, by the way, if you take these people out, we're fine. But because we got a couple of people who you would normally expect to be truly high cost, not simply because those circumstances, that should at least be an opportunity for them to make a justification in that regards.
Rick?
And to Don's earlier point, which I support, we mostly probably shouldn't be focusing on small entities, except maybe where the small entities are the whole of a place. So I'm not, too worried about for medium and large size entities, high cost outliers. At a minimum, and broken record, I said this about population health. I won't say this about each other thing we're going to look at, but we should be, whatever we consider, we should be considering in comparison to statewide. I mean, as Dr. Pan points out, every healthcare entity will have some high cost outliers, and so saying I have some high cost outliers and that's why I went above 3.5%. It's only if you've got more high cost outliers than statewide, which puts some burden on the office to figure that out, or burden on the entity, but the entity's not going to typically have the data to figure out sort of what's the average look like here. And then finally, to Dr. Pan's point about kind of new technology, we are going to have high cost drugs is on this list. New technology arguably should be as well, to at least think about that. I mean, I would also be cautious about those as enforcement considerations, but that I think is different than the sort of high cost outlier story per se.
What about instead of a change in high cost outliers or a difference relative to statewide comparison, but a change from that entity's number or volume of high cost outliers in, let's say, 2022 to the number that they had in 2023? And if we were to factor out the difference from 2022 to 2023 and hold them constant, and then you could determine to what extent, and I hear you wholly that this probably only really applies to relatively smaller groups or entities. But is that I guess I'm just asking for your reaction to that as a way of thinking about when we're looking, and again, this isn't to excuse or waive compliance, we're talking about it in this context for prioritization in terms of how we're thinking about progressive enforcement options and actions.
Yeah, it seems, not crazy. I think, that you still want to have some statewide view of change in high cost outliers from one year to the next to compare to. But yeah, it seems like a plausible approach to be looking. I think the kind of question of how much, is this just kind of random stuff, or is it the result of some conscious decision made about new technology? If CAR T-cell therapy suddenly gets big and, some health system starts doing a whole lot of CAR T at, plus $1 million for each case, that's a different kind of consideration than just, they got some bad luck and more people got hit by a bus this year. But it's a reasonable approach.
Pam?
Yeah, I think CJ, you bring up an important point that it's we're actually looking at change, right? It's not absolute. So what happens is suppose someone actually had fewer high cost folks and then they suddenly picked up a whole bunch more. It's the change we're dinging them on, right? So I think because we're saying growth of 3.5%, we're not saying, well, absolutely you are. We don't have a standard saying you are at a level that's above the state average, and now or you were below and now you're at, right? Basically said if you increase by over 3.5%, then we look at you. So I think certainly a growth. I'd say an interesting question that was raised is, suppose you have an entity that decides that I'm going to randomly pick, let's say, Children's Hospital, that decides they want to bring a subspecialist that will create a new service line that basically is that a sufficient reason? That is actually a deliberate choice to take on more high cost patients, and maybe something that there may be a demand for. To me, that's an interesting question of, do we then, when they say, well, look, our growth, but that was attributable to us opening a new service line that we saw demand for, that contains a group of patients that are generally pretty expensive to take care of. And do we say that's okay, or do we say nope, sorry, no good, you shouldn't be doing stuff like that? That would be an interesting question to try to think about too, whether that or whether they request in advance from our office saying we plan to do this. Are you going to ding us for that or not, right? Whether or something like that. So we do need to think about that.
Yeah, for Dr. Pan, for that example, would that just be kind of a one-time kind of jump, and then once they start serving that population, there'd be kind of stability year over year?
Well, it depends, right? First of all, it's probably not going to be a 1 year jump, right? Because if they bring someone in and they try to build it out, let's say
multi-year.
Yeah, like I decide that I want to bring a transplant surgeon who specializes in a particular type of innovative transplant now, right? That, let's say, pancreatic, something for kids with diabetes, right? And so that may be more expensive, right? And so now you have, and then that's, if it's expensive enough, again, not everything will fall in that category just because you open a new service line. The question is that if they bring in something that would actually be large enough to affect their overall, and they can attribute that most of their increases related to that new service line, would that be like something we'd go, okay, we understand? Or do we say, nope, we're not going to let you do that? So the rest of, you look and say, okay, we carved that out, the rest of it, you're under the percentage. But because we added this, I mean, these are kind of things like we do need to think about, because otherwise we're creating an incentive to say, no, don't even consider doing stuff like that.
And then going back to what Rick, you said about statewide comparisons, like what could be some data sources for that? Yeah. Okay. So, yeah. Okay. Yeah. For high cost claims, and then for hospitals, could the discharge data potentially be? That's just kind of discharge and Okay.
I mean, I'll just note these conversations are generic in nature. And so when we're trying to give feedback to the team who's trying to sort through how these would prioritize, so I just want to appreciate the nuance of that. I don't think the intent here is to deny access to a specialist who can provide state-of-the-art care to children in Children's Hospital in the outlier conversation per se. And so I just want to name that. I agree with Ian that in really thinking about outliers, that should be a one-time look, and it should revert to baseline when those outliers don't exist anymore. And so I think, there's going to need to be a lot of judgment in assessing where you spend your time and trying to understand how big an outlier changed the spending of a particular entity. And so I appreciate the nuance of the conversation because you're trying to get feedback on this, but these conversations are so generic and so anecdotal that it's really hard to pinpoint, I think, with precision, how to assess the weight of these particular criteria. So I just want to name that it's hard to do. And I agree with Rick in general that we should be looking at statewide so that we're looking at something that everybody's looking at as a measure by which we're assessing how much of an outlier there might be. Dr. Pan.
I mean, I appreciate what you're saying. I do think, though, we need to think about different scenarios and what would guide our decision making, because that sends a signal to everyone else about how they should behave. And I think opening a new service line for highly specialized care is not necessarily now exactly how expensive it would be, right? But and there's a lot of there's still a lot of innovation going on. We'll see what happens with the NIH cuts, whether that'll slow down that the federal government is making. But at least we've been an innovator in the United States and particularly in California in a lot of care, and oftentimes that starts out as being very expensive. Hopefully over time the cost goes down, right? But it's not. I don't think we're just like trying to dream up scenarios. These scenarios have actually happened, right? And so we got to figure out how does our office, well, let's put it this way. What does our office tell people when they're trying to make the people running the hospitals and the medical groups and the plans, what should they do? Because our response may actually send the signal to them, no, don't do that, because we're not going to take account of that. Do not do that, right? Because otherwise you might be penalized. So I think that's something we do need to think about, right? What signal do we send to people about if you make a certain type of decision, how would we respond to that? And obviously every actual decision is very personalized, individual, and so forth. But I think these scenarios, while somewhat generic, are not so out of reality that these types of discussions are important for people to know how would this office respond, which can have a lot of influence on their finances to certain types of decisions they decide to make, because they may decide to forego pursuing something because our office would not look on it in a way that they would find that in a way that they would consider to be encouraging or positive, or even potentially negative.
Okay, any other thoughts on patient outliers, high-cost patient outliers? Not CJ, you want to keep going?
All right, so next, historical spending growth. So OCA could evaluate an entity's longer-term historical growth. We do know that we look at an annual spending target, but again, prioritizing enforcement actions, we could evaluate the average growth over several years or could evaluate the number of years that an entity has not met the target. Evaluating historical growth could focus OCA's enforcement capacity on entities that have a consistent pattern of overspending.
Ian?
Thank you. Yeah, in all of this discussion, I keep getting drawn, or I think we all keep getting drawn to the consumer access and affordability piece, and I have a hard time separating this out from that next element. In addition to the, and I think we're teasing out two slightly different things. Who are we prioritizing, and how progressive is the enforcement going to be? I concur we should go after the objectively big fish and the big fish in small ponds. I would add to that we should prioritize those who are starting from a higher baseline compared to others in, dare I say, the sector. One question is whether we have to define a sector for everybody in order to make such an approach possible. But I wonder, can we, that's who I would like to prioritize, is those who are starting from a higher cost point to start with. Do we have the legal flexibility to be more patient with those, more progressive with those who are starting from a lower baseline starting point as compared to those who are higher in the penalty amounts?
We have his baseline spending on the next slide. So yeah, we put this forward as a potential option.
And I just wanted to note for the public that we'll take public comment after board discussion of this item to break it up a bit.
Any comments on historical spending growth? Richard?
It makes sense to me to consider this as, yeah.
Dr. Pam?
Yeah, I think, well, one of the things we might want to think about is trend, right? How are they trending? And so are they getting, because after all, our goal, again, is to try to make things more affordable. So, what trend lines are happening? I think we had a little bit of discussion. We were looking at the high cost outlier hospitals as well. So if it looks like they're trending in the right direction and they're making efforts, at least seems like apparent efforts to try to, that we might, recognize that not everything happens instantaneously, and they are trying. That maybe might give a little more latitude, since they probably know their entity better than we would anyway, to try to continue in that trend.
Okay, let's open it up for public comment on those items that we have discussed here. Population characteristics, high-cost patient outliers, historical spending growth.
All right, we'll open it up for public comment. Please limit your comments to 2 minutes if possible. And looking online, I do see a hand raised, so we're going to start with our virtual attendee. Steve Chertel, I see your hand raised on our end. Or you should be unmuted on our end. You can go ahead. All right, it looks like that hand went down. We'll go to the podium and we'll circle back with that person. Go ahead.
Well, we'll look forward to hearing from Steve Shortell at the advisory committee meeting. Beth Capel with Health Access California. Just to add a bit to the board's discussion and also to put this in the context of some of the correspondence you received, I think this discussion about enforcement considerations is a really important one about how you're going to enforce the spending targets. Much of what you're hearing today makes more sense to us with respect to plans than necessarily to hospitals or physician organizations, but we'll be interested in thinking through those as well. I want to start where Dr. Hernandez concluded, which is to remind us that Californians are entitled to medically necessary care. And when we think about these questions, we don't think about demand in the sense of profitable services, but of Californians' need for clinically appropriate care. So some high-cost outliers are appropriate, but I would also echo that high-cost outliers tend to emerge and disappear. Sovaldi, which was the cause celeb a few years ago, now has competitors and was no longer a subject of discussion. Even the early days of COVID with the reliance on ventilators and ICUs, we have moved past, thankfully. So we do try to move forward to more cost-effective ways to meet conditions, but we also have to take account of the appropriate care that people need, whether it's a multi-million-dollar drug treatment or whatever this year's high-cost outlier is. But I also appreciate the discussion about the comparison to statewide. Thank you.
Thank you. Looking back virtually, Steve, you should be able to unmute on your end. Go ahead.
Yeah, thank you. Yes, 2 quick items. First of all, it may be covered under the high-cost outliers, but the possibility of hospital closures in a given market that will affect the distribution may have ripple effects for other hospitals picking up the care. So perhaps it's embedded under there, but that could be another reason why a high-cost hospital is particularly high cost and may merit an exception. So I don't know. There's data, as we all know, on hospital closures in California, and one could look at the trends of that and a little bit of the impact on other hospitals, historically. So that's one quick item. The other one is how to handle new service lines that Dr. Pan and others have raised. And you certainly don't want to retard innovation and growth and better cost-effective treatments, et cetera, even though they may not be initially cost-effective, they might be over time. So what one could do is require any hospital that's going into a very new service line, a new technology, that they submit to OCA, to the board, what one might call a continuous performance improvement plan, which is budget, what they're going to do to eliminate waste, to streamline the new service, et cetera, how they're going to bring the rate of growth of cost down over time, what their metrics are going to be for the quality and outcomes and patient satisfaction. So that could be something that could accompany that kind of situation. Thank you.
Thank you. Back to the podium.
Janice Rocco with CMA. We would agree with the comments related to high cost outliers and the potential that an entity that has more high cost outliers in one year than they did in another year may, need to have that taken into account as you're looking at whether or not they met the cost target. We would also agree with the comment about adding new service lines and not wanting to discourage that. We also recognize that as a particular healthcare entity stops providing a given service that may be a high cost service, maybe the OB, unit has shut down at a particular hospital and now a different hospital is taking on all of the high risk pregnancies in a given area, whereas they were not before, that's something that needs to be taken into consideration. In terms of the historical spending growth topic, we certainly would hold the view that we did as this legislation to create OCA was going forward, in that to the extent that a particular healthcare entity themselves is starting at a high cost point in a given year, and other entities in the community are much more affordable, we don't want to see a situation where the most affordable entities grow more than 3.5% in a given year, and yet are still far more affordable than a different entity, and yet they're the one that's getting punished for it. So we need to take things like that into account as well. Thank you.
Thank you. All right, seeing no virtual hands raised and no one at the podium, that concludes public comment for this portion of the agenda item.
Okay, CJ, you want to keep going on impact on consumer access and affordability?
Yes, I'll take this slide. So impact on consumer access and affordability, we talked about this a little bit earlier. So this is the degree to which spending has adversely impacted consumer access to affordable care. It could be a statewide viewpoint or a regional market share and impact. So just want to pause here for discussion on this.
Dr. Pan?
So can you just clarify exactly how you would apply this? I guess conceptually, right? But I think in this case, yes. How would you go about doing that? Like, are you certain market share, or what? So
like some of the statewide plans, we could get their enrollment figures from the regulators. So that could give us kind of their market share. We can't just take the plans and then divide their enrollment by the total insured lives, because then not all of them are statewide. So we would need to, for the ones that are more regional plans, we would need to kind of look at their position regionally. So that's for plans. And then for physician orgs, we would need to do something similar, in terms of their size. And then for hospitals, there's also some approaches that could be used there as well.
Yeah. Sorry. So let's take a rural hospital that's like the only hospital for a large distance. Are we giving them more or less latitude?
Yeah. So these enforcement considerations kind of cut both ways, like whether we should prioritize them more or prioritize them less. A rural hospital, they would be more dominant in their market because they're essentially the only option. So we didn't want to put out a factor that's we're just looking at market size or share, because then that doesn't account for situations like that. For a regional hospital, you could kind of look at hospital referral regions and kind of look at if there's more than one hospital in an area, you could kind of look at kind of their catchment area. But for a rural hospital, as in your example, like that, if they're the only option, then that might kind of warrant some prioritization by OCA.
Okay, in terms of prioritization of enforcement?
Potentially, but then, there's other factors at play in terms of, if they're primarily public payer mix, like their rates are essentially administratively set. So it's kind of, among other factors, among other enforcement considerations, kind of I'm just looking at this one in isolation, but we would take them into account with other factors.
Okay. Yeah, so some clarity on that. I realize it's going to, in some senses, the challenge is that when you think about market share, right? You have, if someone's like the only hospital, that's one end, essentially 100% or near 100%, you got to be careful because, and then, the other end, it doesn't matter, right? You're down 10%, you may say, well, okay, you're just too small, unless, because we don't have infinite resources, right? So and then in the middle is where you're like, okay, there's the opportunity because there's some competition and so forth, and we can sort of like, okay, you're going. So, but I do think that it'd be helpful to have more clarity, particularly when we talk about rural communities where, fortunately, we're probably not going to be able to goose up a lot of extra competition just because of the nature, the population density and so forth.
Ian?
In a similar vein to my previous comments, to me on this, I'd like to see us focus particularly on those who are driving price, where the price increases are the overwhelming factor in why they're not meeting the target. Now, I understand it's sometimes a little hard to separate out the degree to which it's price versus volume, and then you get into the discussion that I don't think we want to be getting into about what is appropriate volume and so forth. But yeah, I would prioritize those who are really aggressively driving prices.
Okay, keep going.
I'll take us to our next one, which is investments in primary and preventative care. So under this one, we could evaluate to which increased spending or investments in primary and preventative care caused an entity to exceed the spending target. So, just to give you a little more color on this one, we will be collecting primary care spending data, but that's going to be for payers. And then physician organizations and hospitals, will benefit from some of those payer investments. They could also make investments on their own in primary care. So this one, given OCA's, focus on promoting increased investment in primary care, we included this. We wanted to open kind of what types of information should we collect, kind of how should we think about this. Looking forward to your feedback.
Dr.
Pan? So conceptually sounds good. I guess a caution is this, right? And I think is, for example, if the investment is basically consolidation, I bought up all the primary care practices. They could frame that as investment in primary care, and So I just some clarity would be helpful. I mean, we're talking plans, but I'm also thinking we have other entities, and exactly what kind of investment are they making, and how is that being manifested is going to be important.
Yes, in the statute, it does call for primary care investments, and the goal is to shift spending away from the kind of unnecessary care or expensive specialty care. Some of the kind of savings or cost avoidance may not materialize until later. So we would be looking for that. So it's not simply just kind of acquisition of primary care practices, but to what end?
Yeah, I'm super supportive, as the board is, on increasing investment in primary care. I do think where costs go up associated with this, we should understand when we can expect costs to come down post that investment. So as we think about this component, really understanding, okay, there may be a one-time infrastructure investment or the like. It shouldn't be a sustained increase in costs. It should actually take that entity, whatever entity it might be, over time, its costs down, and we should have a sense of when that might happen.
There it goes. I also I'm just, cognizant of the fact that we have these shortages in a lot of the state. So we just did an analysis at CalPERS, and 45% of our members live in a designated behavioral health or primary care shortage area, and we don't have that many people in rural California, and mostly they're in the big market. So that is in itself, I think, pretty telling. It might be helpful to tease some of this out. I know you have a terrific team looking at access challenges in primary care, and it might be helpful at some point. I don't want to add to the plate, but in sort of teasing out key strategies, so you can sort of differentiate between constructive and box checking approaches to this, as you're thinking about, because the probability of lots of box checking responses to this, I think, are very high, and putting requirements into a space where there just are limited solutions is, I think, kind of problematic and not really constructive. So I think digging in a little bit deeper is probably worth the time.
I appreciate that, Don. I would also note here that we're also talking about preventative services, and those don't often require a primary care physician to implement. And so really the focus here as well on preventative care is something that I think, in addition to the situation that we have around primary care, really beginning to think about how we get much better in systems and in delivery capabilities around basic preventative care and population-based care, I think would be super helpful in this space.
Yes, so I'll take us to the next one. So entity baseline costs. So, just as Board Member Lewis mentioned, not all entities are going to be operating from the same baseline. So, in addition to measuring and comparing the entities' percentage growth, OCA could prioritize enforcement actions with entities that have inexplicably high costs and absolute high growth. And, this wouldn't require establishing a sector. It would just be kind of more prioritizing, certain, among physician organizations, looking at their baseline costs among hospitals and then among health plans.
Rick?
As other board members have expressed, this makes a lot of sense to me. Yes.
Yeah, I completely concur. Anybody else? Okay, keep going. High-cost drugs.
So we did have an extended conversation last month about high-cost drugs. We did feel it was an important. It was important to include this to give OCA that flexibility during enforcement to consider these issues. So the description we have here is new therapies and new uses of existing drugs may lead to unusually high spending growth due to increases in demand, cost, or availability. OCA would need to evaluate the extent of control and any excessive market or markup behavior by entities when evaluating high-cost drugs as an enforcement consideration.
Rick?
Echoing earlier comments, if we are going to be comparing a given entity to statewide, then, and if we are going to be focusing on entities that have exceeded the target by more than many other entities may have, so, the high cost outliers, I think this is unlikely to be a consideration that will matter much. That is, if we're looking at, say, GLP-1s, most entities in the state are going to be affected by that, unless, the particular entity we're looking at is much more affected than others. and if we are focusing on entities that have higher cost than other entities, this is not going to be the reason. Again, maybe there is some entity that, for some reason, GLP-1s is, are hitting them much harder than others, and if so, that that could be taken into account. But it's, I think that's likely to be the exception rather than the rule.
For kind of some of the you mentioned technology earlier, so like the cell and gene therapies kind of.
Yeah, so I was going to save that for your last, are there other considerations? But if you want to discuss that now, I mean, I think Dr. Pan made a strong point earlier that and we haven't really discussed this, and it's not sort of explicitly, I think, one of the items here, but to the extent that hospitals or health systems are, considering investments in new lines of therapy, those will be tough questions. I mean, and this is not per se a certificate of need body, but it raises the question of how the office and the board would respond. It sort of makes conceptual sense to say, yes, if a hospital is deciding to, or health system is deciding to make an investment that's going to raise spending, and arguably that investment is going to lead to improvements in health outcomes, I'm sure the office doesn't want to be in a position of saying, no, that's not okay. On the other hand, the office probably isn't really set up to figure out whether it improves health outcomes. You probably need to, well, I'd be interested in your response of what you're thinking about how to deal with that kind of a scenario. But it will be a common scenario, or not uncommon scenario, and one that I think we should probably have some discussion consideration of.
Yeah, Vishal, one thing to think about is, there are entities like ICER, for example, that really tries to understand the impact of a new intervention, a new treatment, a new capability, and really is set up to do the kind of thing that Rick is describing. So I don't think that's a function we would try to do at OCA, but really think about, is there a way in those situations, should that arise, that we go to an entity like that and ask them to provide us an analysis, allow us to answer hypothetically the question of, is this investment in terms of the potential outcome and impact, worth the increase spent?
Ian? Yeah, this may have been raised in the last meeting, but I just flagged there are high-cost drugs and technologies that are coming down in price rapidly right now and coming off patent and what have you. And that's a reason that an entity should be well underneath the target insofar as those drugs are a factor. So in kind of keeping with that, I agree that the high-cost drugs should be something we think about, and technologies maybe something we think about as for the statewide target, but not on the individual entity level.
Dr. Pan?
Yeah, I think one of the things we have to acknowledge is sort of the dynamic nature of innovation, right? Which is, you're right. So, example, a procedure, and by the way, I mean, I know this is high-cost drugs, and that's probably the most common example that'll come up, but it's not just drugs, it's certain types of procedures or devices and so forth. And probably in their initial phases, right? They're not beyond experimental. We're not dealing with experimental, right? But even then, they'll be more expensive in the beginning, and when people, through both volume, experience, and training, the price should go down. And so we might want to think about how we address that, because what we don't want to do is discourage people from starting the innovation, especially hopefully that goes down. Drugs are actually more straightforward because, for good or for bad, unfortunately, the manufacturer and whatever other entities will set what the price is, and then and then we sort of live with it. But anyway, I think that we probably do want to think about what kind of mechanisms do we have to take account of essentially high cost treatments that are fairly innovative, and yet, you said, like over time, we would expect the average price to go down. Exactly what that curve will be may not be the same for everything, but it should go down over time. And exactly how do we take account of that as someone submits a report and says, oh, by the way, part of the reason I'm over targets because I'm doing this high cost something, X or nothing, or treatment of some sort, and how we take account of, okay, you're reporting this now, what happens 3-5 years later with that, and then now you have another one coming up, right? And the fact that we basically say we only take increases, we don't do decreases. So so how exactly we manage that dynamic?
Should we move on to acts of God, Rick?
No, no acts of God, but just to Ian's point, I mean, the high-cost drugs, at least if we're thinking of them as outpatient drugs that we pick up at the pharmacy, those, I think, as I've said before, are likely to be fairly uniform across health plans, across health systems. Maybe there's something special. To the extent that it's high-cost drugs that are purchased by hospitals for use on inpatient, that may be more heterogeneous, where some hospitals get hit really hard because they're using particular, chemotherapy drugs, and we've had the discussion of how much, to what extent is price under control. On the technology side, that is likely to be heterogeneous across hospitals. Different hospitals kind of specialize and are doing different things. But to the broader question of, to what extent should the targets be adjusting for this, I think of joint replacements. And to Dr. Penn's point, the cost of joint replacement therapy, I think, has gone down substantially, but the volume has gone up tremendously as it becomes better. We probably should be considering the next version of, or the next kind of joint replacement as we're considering enforcement. I don't think we want to say no, we'd be better off without all of that. But Don's going to disagree.
No, I wasn't going to disagree, because I may need joint replacement sometime. But I do worry that, so we've got a baseline here that is spending growth at 3% annually. If we start to get into all of these other things, what we're essentially saying is, okay, so table stakes is 3% annually plus anything good you're doing, right? and if you're investing, if you're spending the money on CAR T, ICER has told us that CAR T is a good investment because the quality adjusted life years that come out of CAR T therapy make it worth the very high cost. And if we're doing these other things, and then we're getting into this question that is, as you all noted, problematic for the office itself of, so like differentiating between Da Vinci robots and CAR T therapy and which one is in which category. I think we're going to need to figure out a way of dealing with this without having a laundry list of things that we like that are add-ons, or we're going to have a meaningless spending growth target. But just, it's.
Okay, Michelle, you want to keep going? Changes in state and federal
Yes, I'll take us to our last two enforcement considerations. So the first one is changes in state and federal law. So entities may be affected by changes in state or federal law. At the state level, there's benefit changes or mandates, mandated wage increases. There's also the impacts of federal tariffs, which may increase entity spending. OCA could also consider the extent to which these changes impacted an entity's spending growth. Sudden and unexpected changes in federal trade and fiscal policy could also impact the cost of care. If the office sees a systematic effect that applies uniformly across the healthcare system or to sectors of the healthcare system, we could present that information to the board to consider in future spending target setting. Okay, so I'll take us to.
Can I just ask a question about this on your last point? You could present information for future spender target setting. Does the board have the ability to say we set a target of 3.5% for 2026, but tariffs are going to cause, going to cause much bigger increases? Probably a bad example because they probably won't. But something has happened, and I know the 2026 target has already been set, but do we have the ability to say actually it should be some other number, or is that not legally possible?
We would still need to follow the same March and June timeframe, so it's too late to change it for 2026. But we could, the enforcement considerations is kind of a way to articulate how we would handle those types of situations.
Dr. Pan?
Yeah, I think this goes back to what you said earlier. We should be looking at it every year in terms of at least examining it. Don't need to change it every year, but I think based on whatever most recent information we have, because obviously this process is important, but it is on the back end, right? And so I think that, obviously there's going to be a data lag too between the information we have and our decision to make whatever cost target decision we make. So, but I do think that, clearly the federal government, the government overall, since most of the healthcare spend does come through the government, is a major player. So decisions or changes made by governments, including we just recently talked about HR1, are going to have an impact in some way. Now, exactly what it does to the overall, right? But if we're looking at different lines and so forth, Medicaid versus Medicare versus commercial, there's going to be some changes because of those decisions. And so, we do need to, we have to demonstrate to entities we're regulating that we acknowledge and understand the impacts those are having on those entities, because some of these are pretty substantial.
Yeah, I agree with that comment, and I think it is important to have a stake in the ground by which we are trying to hold entities accountable, and as the environment changes and the schedules that we have to look at prospective spending targets would be the time to take those into account. But I think we should be mindful that we're not moving the goal line in the middle of the reporting period. So, yeah, I think we're trying to move an entire industry. It's a hard move. There's a lot of moving parts in the environment. We shouldn't ignore them, but we should be pretty firm in our schedule by which we review them, such that we're not moving the targets as we're going.
All right. I'll take us to our last enforcement consideration, which is acts of gods or catastrophic events. So these are events that are unforeseeable, often caused by forces of nature and beyond human control. The office could assess the extent to which it was foreseeable, or if the entity failed to take reasonable precautions to mitigate damage. OCA could take into account acts of gods and catastrophic events as contributing factors to an entity's excess spending. So I'll just kind of take us to our last slide, and we could discussed this one as well, but you know, in addition to acts of God, are there other considerations the office should evaluate when assessing an entity's performance and determining whether future enforcement actions are warranted?
So, Vishal, I don't understand your second bullet under catastrophic events. If it was foreseeable, I mean, I don't know many entities that can foresee an act of God. Catastrophic events as in it was catastrophic to that entity and they should have done something. So I'm trying to understand how you think about this in this category. A foreseeable event that they were not adequately prepared for, didn't mitigate appropriately. Give me an example of what you're talking
about. You know, this one, an entity could claim it's a catastrophic event, but then we'd want to learn more. I don't know if we have any examples top of mind. But.
Yeah, I would also just point to seismic compliance. So if a hospital didn't meet its standard, I mean, we will have big earthquakes in California, and if a hospital hasn't sufficiently planned and implemented seismic safety standards on their building, for example.
Yeah, we will have. We won't call on one, but we will definitely have. The earth will continue to shake in California, I'm sure. I guess my concern here is how we assess the reasonableness of mitigating those damages. Obviously, if they're out of compliance with a state law, that's a pretty definitive standard. After that, I think what reasonable precautions are, how we assess them would be challenging, I'll just say.
Yeah, I guess the only other circumstances, gross negligence is perhaps proven by, court or something that resulted in that catastrophe. So, but otherwise, you're right. I mean, I'm trying to think like what other examples we come up with that. So.
I mean, we do have fires, obviously, so there's that phenomenon as well, but I don't know that an entity would have control over being in a fire zone or being part of a fire or the like. So I'm just trying to understand those circumstances where people...
You're in Sacramento flood, but it's the federal and state government that have to maintain the levees, so...
Any, Rick?
Just, I don't have an answer to this. What does this middle bullet mean? But on the broader acts of God, yes, certainly if there's an earthquake or tsunami, and many people in the service area need healthcare, and that's what causes healthcare spending to go up. The office should be considering that. That makes perfect sense to me. One question: I know the statute has a specific language about increases in negotiated labor rates. Does that come in someplace else? That's not kind of part of what we're thinking about here.
Yeah, that's not a back end to whether to decide to enforce against a healthcare entity or a provider in that case. So the organized labor cost adjustment, entities could show that a labor agreement is going to result in costs growing faster than the target, then they would submit data to us to substantiate it, and then we would adjust the target. That's more of a front end adjustment.
Have any entities done that for 2026?
Not yet.
Dr. Pan?
Actually, one other act of God question. So, act of God could be not something that happened to the entity itself, but to the patient population. Is that so? Well, let's say obviously our most recent act of God was COVID, right? And that clearly had an impact on health facilities, both actually. So now that of course was nationwide, worldwide. So perhaps the impact was, I wouldn't say entirely even, but across. But you could have other types of events that could happen. So even a seismic event where the hospital's still standing and operating, but you have a lot of injured people and et cetera. And actually, we're not exactly sure which direction it will go, right? Because maybe everyone's being evacuated and removed, or the other way around. That now they're so I was wondering, is that when you say act of God, that also things that might impact actually the people who that are serving? Yeah, not just the entity itself.
Correct.
Okay. And then I did have a question about, you said other enforcement considerations, if you maybe bring.
Please.
Yeah. So I realize it's not probably for year one, but, and we sort of aren't talking about the technical assistance yet, but eventually we do have to consider, okay, so you have an entity that didn't meet the cost target. We provided technical assistance, some other types of plans, et cetera. They followed them. And they're still above the target. Now, they did what we asked them to. What then? So maybe it's not a question to answer right now, but I think that's something that, after all, now that they basically said, okay, you tell us what to do, we'll do that. And
Dr.
they do
Patna,
that,
it
yeah.
wasn't my impression that we would give them a detailed plan to follow to reduce their spending. My impression of the kind of technical assistance we would provide them is data and understanding perhaps what others have done to be able to reduce spend, but not specifically how to manage their entity into the spending.
Well,
so
yes.
we should have a common
Okay.
understanding of how we think about technical
Yeah.
assistance. But
Okay, well,
That's an October discussion.
it's
Yeah,
coming up.
yeah.
Okay, well.
okay, yeah, but for example, one of the things we need to do is a corrective action plan. Perhaps not just technical assistance, corrective action plan farther down the line. And they follow that corrective action plan. And the costs are still high, or even that corrective action plan did not have, drove up the costs even. So I think to a certain extent, at the point where we're basically directing the hospital to do certain things, and maybe not everything they do, but certain things, we have to accept some responsibility for that.
In that case, the performance improvement plan, it is a time limited performance improvement plan. It could also be updated. It's supposed to have significant milestones, quantifiable. So it could be measurable is what I'm trying to say. Just like Massachusetts, they had a measurable plan as well. So for Mass Brigham, but it's not just a bunch of things they're doing, and we're not, and they're not showing kind of data to back it up.
No, I agree. In fact, we should have milestones and measures and so forth. I'm saying that if they do meet those measures and so forth, then, right? So, okay.
You're saying if there's a disconnect between they did all those, but then spending still goes up? Okay. We'll have to think about that. I can't think of how that would happen, but okay.
Yeah.
Could I just understand? I look forward to the discussion in October of the technical assistance. Just from my thinking, is your thought to combine that discussion with the corrective action plan, or would that be another conversation down the road?
In October, we plan to, or actually, we could move to the timeline slide, which is the last one. We'll continue discussing assessing performance in October, and then in November and December, we'll move on to technical assistance and public testimony. So this could shift. We may bring technical assistance to you in October if we're ready. And then in January or early next year, we'll move into performance improvement plans and then penalties later in the spring. The last bubble here does show kind of, we do need to codify these processes and enforcement considerations in regulation.
Okay, any other comments from the board on enforcement considerations or any of the other items we have talked about? Okay, if not, let's open it up for public comment, please.
We'll now take public comment on this agenda item, looking virtually, seeing no hands raised at this time. Noting for the record, we have about 100 virtual attendees. We will go to the podium.
Janice Rocco with CMA. In terms of the discussion about changes in state and federal law, certainly to the extent that that's increasing costs, those should be considered. And one thing that comes to my mind is with HR1, we're going to have a lot of folks who lose out their health insurance coverage for a period of time. And then hopefully we're going to have a different federal leadership and people will regain coverage. And so folks will have a lot of unmet healthcare needs, and we're not doing, health status risk adjustment. So to the extent that folks suddenly come back into the system and certain providers are seeing folks who went without healthcare for a period of years because they lost their health insurance, things like that need to be taken into account in addition to all the other discussions that we've had about HR1. In terms of investments in primary care, it makes sense to evaluate the degree to which those investments are leading an entity to exceed the cost target. High-cost drugs, if you have a new high-cost drug and a particular healthcare entity, a physician office administers that drug, but it didn't exist the year before, that's going to impact the picture there. So I do think that the things we've been talking about today, most of these bullet points are ones where, yes, we need to consider this when we look at whether or not an entity met the cost target and factor that into what the consequences should be. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Good afternoon, board members. Jenny Nguyen with the California Hospital Association. We are glad to learn about OCA's initial thinking of the reasonable factors for assessing enforcement on entities that exceed the spending target, especially as the current established spending targets do not account for key drivers of healthcare spending. We believe that the proposed list should include additional reasonable factors that are critically important for consideration and evaluation by OCA. We've shared previously some of these factors in our June 2025 comment letter and would highlight a few here today. For example, factors outside of an entity's control, including macroeconomic trends like rising inflation, payer mix, and changes in insurance coverage and uncompensated care, should be included. Conversely, factors that support and expand patient care, like investment and expansion of services, technology, and programs, as mentioned today by several board members, should also be accounted for as it contributes to equitable, high value, and high quality care for patients. Overall, a meaningful and reasonable enforcement process is critically needed to balance the goal of improved affordability without sacrificing healthcare access, quality, and providers' ability to sustainably operate in their communities. We look forward to continued discussions on this subject, including getting clarity on how the office will incorporate the enforcement considerations into the enforcement process over the several board meetings. Thank you.
Thank you. Looking back virtually, no hands raised. Back to the podium.
Beth, excuse me, Beth Capel, Health Access California. We appreciate the discussion of the enforcement considerations. We do have a concern that the net result will be to make the target less meaningful. And we are balancing those two as we look forward. We appreciate the staff's acknowledgement that in some instances there's excessive markup. And we've certainly gone through, and I think our experience with Monterey a year ago was a useful learning experience that in some cases the explanations given don't hold up to further scrutiny. about whether an entity with a very high cost basis has higher wages or is otherwise justified in those very high costs. We would, with respect to other enforcement considerations, encourage transparency on what those enforcement considerations are and what applies to what entity. We're going to, so that if an entity exceeds the target because of a particular reason, we know that. We don't ask, it's not about an extremely detailed analysis. It's about what I would call sort of a case summary or an overview of what the reasons are. I think that will be important for everyone involved, the board, the staff, and the many interested parties as you move forward. So we would encourage, we will make a number of recommendations about how to accomplish transparency within the framework of the law. Thank you.
Thank you. Looking virtually, we have one hand raised. Kelly Brooks, go ahead. Kelly, you're unmuted on our end. You might need to unmute on yours. We can't hear you. Kelly, we're unable to hear you. If you look in the top right-hand corner, you might see the little mic with an X next to it. If you can click that, you might be able to unmute on your end. All right, looking back to the room, it doesn't look like we have any other folks in the room for public comment. Kelly, we'll give it just another moment. And of course, we'd invite anybody to provide written public comment at the email address noted on today's agenda and the posted materials. All right, we're unable to hear our virtual person, so that concludes public comment on this item.
There's public comment in the room.
I have general public comment.
Okay, let's go ahead and move to general public comment.
Okay, good afternoon this time, board members. This is Victoria Valencia at the California Hospital Association. Last month, in the context of drug and hospital pricing, OCA mentioned a tool, the NASHB Hospital Cost Tool. And we just want to highlight that unfortunately this tool contains significant flaws. For example, it systematically inflates hospital margins by including only Medicare allowable costs in its calculation of margin. This excludes costs related to medical education and training, physician integration services, community benefit programs, but at the same time, it still counts all revenues. So when we compared the NASHB California hospital data to HCAI's AFDR financial data, revenues matched within 1%, but expenses were on average 15% lower in the NASHB tool, which when we calculated this and analyzed it, resulted in margins on average 16 percentage points higher than reality. One California hospital actually went from a margin of negative 10% to positive 20% due to the tool's arbitrary exclusion of whole categories of expenses. Using a tool that provides such an inaccurate picture of hospital finances for public policy raises serious questions, and we urge OCA to fully investigate this tool before using it in the context of hospital pricing or in the context of exceptions to spending growth targets. Thank you.
Thank you.
Any other general public comment? Seeing none, hearing none, that concludes our agenda for today. If there's nothing else from the board, we are adjourned.